Good morning, everyone. I'm Dave Anderson, and I serve as chair of the Master's Level Psychology Licensed Clinical Psychotherapy Advisory Committee of the Kansas Behavioral Sciences Regulatory Board. I ask the members of the advisory committee to respond to a roll call to signify their presence at this open meeting that is being conducted remotely by conference call and other electronic meeting. Donna Hunter-Queel.
I think Donna may be absent for the meeting today.
Okay. Travis Hamrick.
Here.
Rebecca Javara.
I am here.
Lauren Luck.
Here.
Iris Pauley.
Here.
Joshua Tangaway.
Here.
Murray Wolf.
I think
Here.
Kari might. Oh, yeah.
I'm here. I'm just going to be commuting, so I will have my video off and muted so you all don't get background noise today, but I'll chime in when I need it. So,
Great, thank you. I note the following BSRB staff members are also present. David Fye.
Here.
Leslie Allen.
Here.
Next, David Fye will read a message concerning this meeting being held remotely.
This is David Fye, Executive Director for the Behavioral Sciences Regulatory Board. Public comment allows the public to address the advisory committee about its concerns, but the Kansas Open Meeting Act, or KOMA, does not require the advisory committee to provide public comment or answer questions from individuals. Individuals requesting to provide public comment could contact the executive director prior to the meeting by sending an email to david.fye@ks.gov. There will be no public comment at this meeting, as no individuals have requested to provide public comment. Because we are conducting this meeting publicly, remotely, by conference call and other teleconference ability, I state for the record the following information. Public access to this meeting is being conducted by medium of interactive communication that allows members of the public without cost to attend the meeting through the use of the conference call and on the board's YouTube channel. While the meeting is conducted remotely, the requirements of the KOMA are not suspended, so we will be conducting this meeting pursuant to the KOMA. On September 19th, 2022, we sent notice of the advisory committee meeting to all individuals who had requested notice of the advisory committee meetings. The notice was also posted on the board's website, bsrb.ks.gov. You may obtain a copy of the notice at that website. An agenda and other meeting materials have been posted to the board's website, and you may request a copy of the agenda specifically by sending an email to david.fye@ks.gov with the subject line request for the agenda, and it will be sent to you. The notice contains information for the conference call and the YouTube channel that allow the members of the public to attend the meeting free of charge. The notice also states that if there are any technical issues during the meeting, you may call the board office at 785-296-3240 or send an email to bsrb@ks.gov. A recording of the meeting will be available on the BSRB YouTube channel following the conclusion of the meeting by using the link to the meeting on the agenda.
Thank you, Dave. The meeting is now called to order, and the advisory committee will begin its discussion. Approval of agenda or additions to the agenda. Does anyone have any additions to the agenda? Okay. I would accept a motion to accept the agenda then.
So moved.
so moved.
I think Kari might have been first on that one.
Okay.
I second.
Thank you. Next, we'll review and approve the minutes from our meeting in August. Has everybody had an opportunity to review the minutes? The additions or changes to the minutes? Seeing none, I would entertain a motion to accept the minutes as written.
So moved.
Second?
Second.
Is anyone else having difficulty hearing the conference room?
Is it too faint for you to hear right now?
I can barely hear.
Okay. Why don't you move the microphone a little bit closer to you?
Is this better?
A little bit, but if everyone else can hear, okay, maybe it's my computer, but I can hear the other people at a normal volume, and the conference room sounds quiet.
Okay. maybe we'll just have to talk a little bit louder.
Okay.
But we'll try to be a little bit louder in terms of that.
I move this closer.
Sure. That helps too.
All right, I guess we're ready for the executive director's report. Is that better? All right.
Okay, I'll go ahead and provide the advisory committee with some updates concerning some different matters. First, with some agency updates, we are still under the governor's direction related to the pandemic that limits our ability to hold full meetings of the board or advisory committee in in-state buildings, but we are in contact with the governor's office about those restrictions, and if we receive additional flexibility, we will let you know so we can start having conversations about having the option to meet in person here at the board office. In terms of other updates, every agency is required to submit a budget. We submitted a budget on behalf of the BSRB by September 15th, and that had adjustments for the current year's expenditures and also expenditures for the next two fiscal years, fiscal year 24 and fiscal year 25. Also, I wanted to let you know in terms of BSRB outreach, the Assistant Director, Leslie Allen, and I have been speaking to different groups of students in terms of licensing information and also disciplinary information, and to give them some additional information about resources we have on the website so that they can be up to speed on issues as they approach graduation and attempting to become licensed as a professional. I'm going to provide a few updates from the last full board meeting, the meeting of the board that took place on September 12th. During that meeting, the board heard from a few different groups and presenters with some information. One presenter was from a company called CE Broker, which provided some alternative information to the board in terms of an alternative method of handling audits of continuing education hours. And so the board did not have a discussion or reach a decision on working with that entity, but there is some helpful information. So if you're interested in hearing some of that presentation, you can go back and watch some of the meeting from September 12th. Additionally, the board received information from a representative of Heart of America Professional Network on a possible impaired provider program. The BSRB currently does not have such a program, but there are other state agencies that use a program for impaired professionals that are licensed by those professions, and some of the other entities similar to the BSRB have those in other states. So they collected some information and plan to discuss impaired provider programs further. Additionally, the board not only licenses the professionals, but also investigates complaints against professionals. And as part of that responsibility, the board uses an investigation policy to guide the work of the Complaint Review Committee, which is 5 members of the board that serve to review those investigations that the 2 investigators for the BSRB put together, and then discuss those and determine if there were any disciplinary violations and what the remedies should be. That investigation policy is in the process of being updated, and so the board made some changes at the last meeting, and it's anticipated that the board will make further changes at the full November board meeting. Once those changes are complete, we will post a revised policy on the BSRB website. Additionally, the board attempts to meet off-site once a year for an all-day planning meeting, and the board determined they would like to have that all-day planning meeting this coming Monday on October 24th, 2022. It'll be held in Olathe, and the specific address and information for that off-site planning meeting is posted on the BSRB website if you have any questions. At a previous meeting, I had been providing a little bit of updates in terms of some disciplinary actions regarding all professionals, but specifically for the master's level psychologist and licensed clinical psychotherapist. I did talk with the investigators for the board. So far in fiscal year 2023, which began on July 1st, for all professions, there have been 47 complaints that have been received by the BSRB. There were 11 in July, 26 in August, and 10 in September. Out of those 47 for the master's level psychology and licensed clinical psychotherapy, there were 6 complaints. And so overall, the yearly trend for complaints, similar to what we saw last year, so far just 1 quarter into the fiscal year. In terms of types of complaints that are being received currently, one trend that our investigators noticed they are seeing is when individuals leave their place of employment, whether they have acted appropriately in terms of continuity of care, or whether they provided proper notice prior to leaving their place of employment. So that's one of the current trends. There, of course, are always going to be some complaints issued by the board for individuals if there's issues with continuing education, and then there's other complaints that we receive from the public. But those are the main current trends we're seeing right now, tend to be individuals leaving employment. In terms of what we saw at the last advisory committee meeting, there really hasn't been a significant uptake in complaints against professionals in this profession, but it is higher proportionally than some of the other professions, but that could be attributable to some of the work being done. It's hard to say. The sample size is pretty small, 6 out of 47, so we can't really reach any conclusions. And it is important to note that violations are very different from complaints, because while we encourage individuals to file complaints if they believe there's been a violation of the regulations, those do not amount to violations in a significant number of cases. So I want to provide some legislative updates as well. In terms of legislative meetings, the legislature usually meets from January until April, sometimes in May. In the off months, they hold interim committee meetings. This fall, there has been a committee that focuses on general health topics. That is the Robert G. Bob Bethel Joint Committee on Home and Community-Based Services and Can Care Oversight. There was a meeting on September 27th, and they asked me to come and speak on a few recommendations that had carried over from a special committee that met during the fall of 2021. That committee focused on mental health modernization and reform, and most of the recommendations were for larger agencies like the Kansas Department for Age and Disability Services, Department for Children and Families. So we were not the primary agency on any of the recommendations, but they asked us to comment on actions the board has taken concerning topics such as workforce and also telehealth. And so I spoke to the committee about some of the conversations the board has had recently, some of the recommendations, and then also the work through the unprofessional conduct regulations, specifically as it involved telehealth type matters too. Yesterday, the assistant director and I were at a different legislative meeting. There is a joint committee on administrative rules and regulations, and we spoke concerning regulatory changes that have been determined by the board, mostly relating to legislation that passed during the 2021 legislative session concerning changes to the number of supervision hours and direct client contact hours and hours of clinical experience for individuals trying to reach a clinical license. There's also some changes in the regulations involving the ability to get supervision by televideo instead of just in person. Some of the ratios have changed in terms of the number of supervision hours per direct client contact hours and the number of supervision hours that you have to have. And then there were some other matters too. Those regulation changes have been posted on the BSRB website as proposed changes. Those are under, they're broken out by profession. They're available for review. And additionally, the BSRB will be having an open meeting to allow for public comment on the regulations. And that will be on Tuesday, November 8th at 10 a.m. And then individuals can submit written comments prior to that, and there's some information on how to do that that's posted on the front page of the BSRB website. But during that public meeting, there's also an opportunity to provide additional written comments or oral comments at that meeting as well. And then after that period closes, they'll come back before the board for a final decision on implementing those regulations. So with that, I'll go ahead and end my report, and I can answer any questions.
Thank you, Dave. Any questions? All right, hearing none, we'll move on to old business and a continued discussion on types of testing assessments being administered by psychology programs. Josh, I think you were going to do some looking into this for us.
Yeah, so I visited with previous director of a school psych program in Kansas and spoke for a while. So in terms of testing classes that are offered, there seems to be a spectrum from 1 to 2 classes offered throughout a program, up to 3 or 4 possibly, that can cover, the spectrum of testing from cognitive tests for children and for adults, achievement testing, personality testing, behavioral or adaptive scales. so a pretty wide spectrum and kind of how those classes are broken up as well. We talked about the whole in residence component, as well as virtual, 100% virtual, in residence, hybrid. And what essentially we talked about is that it would be what his opinion was, is that it would be very difficult to be 100% virtual with these testing courses. And if that were even to happen, his thought was, you would have to have a very long synchronous component, like hours per day, which is very difficult to do. They actually had to do that during the COVID, during one of the COVID summers, and they did a 40-hour week on Zoom in order to meet what they had to meet. So right now, I know that Fort Hays is the only one that does like a hybrid type of clinical program, to my knowledge at least. And the hybrid component is essentially for the testing class, for the appraiser of children class, there has to be a week spent in person, which is a 40-hour week where they do intensive skill testing during that week. And then they coordinate taking tests home and essentially having to test children. One of those sessions is videoed and there's feedback given back to the graduate student on that testing session. The other, I think they have to do a total of 4, and the other 3 are not videoed, but they have to, hand score and type it all up and do all that, and then receive feedback on that. So I'm looking at my notes here for other things. One thing that was brought up that we talked about, and some people on this call may know more about it than I do, because I don't do a lot of cognitive testing currently, but he did talk about how a lot of the Wexler scales are offered virtually now, where there can essentially be like a psychologist proctor, then they're administering it virtually to somebody else somewhere else. And there may be like essentially like a helper on the other end, maybe some sort of assistant on the other end that may help with some things, but those things can be offered virtually now too. So I thought that was interesting, just kind of maybe a peek into the future, so to speak, with what could be coming down the line. So I can answer questions that people have, or any thoughts anybody has. That wasn't everything we talked about, but that's probably a good rundown.
Thanks, Josh. Travis, just as a bit of background, so one of the things we've been talking about is the in-residence component of the regulations for our specific profession. Some, well, obviously more and more degree programs are available online, and some of them are almost totally virtual, and there are aspects of our particular profession and training where we have discussed whether that would even be possible, particularly around how people would develop competencies around administering psychological testing. And so that's what Josh was talking about in terms of visiting with the school psychology program to see how they were doing that. And we don't have to change our in-residence requirements. It's just something we've been talking about. We get a number of applicants who go through programs where that is the snag they hit. Many of the virtual universities, there's essentially no time spent on quote-unquote campus. Many of them meet. They get together at like large hotels regionally, and they bring their students in and they have some intensive time together. but our regulations are very specific. And so Leslie could probably talk to the number of times we run into that issue in particular for people trying to get licensed at this level.
We've had one person that was denied licensure in the past 6 months, and we have a lot of phone calls that come in asking about online universities and whether or not they would meet our requirements.
I think the online universities are doing a better job of telling people to check in each state that they're thinking about getting licensed, because every state is different. And so hopefully we're having fewer people surprised by the fact that they cannot get licensed. Some of them are going through doctoral level programs and starting there. And if they can't get that license, then they're trying to drop down and see if they can get licensed as a master's level psychologist. And if there's an issue that trips them up, it's often this one. But it sounds like not as much anymore.
Right.
So feedback on that, feedback on Josh's information, and Josh, thanks for doing that.
I think the feedback was similar kind of to what we talked about previously, like the best option would be maybe a hybrid type approach to that.
Yeah, that's what he essentially said. And I really trust this person. He's put a lot of time and effort into this on campus versus virtual hybrid situation, and knows a lot about testing. And he kind of echoed essentially what the board has been saying with, it would be really hard to do 100% virtual and have that up to a consistent standard on a large level. Any one school might do a really good job with it, but maybe difficult to do on a large scale. And the hybrid, although difficult for students sometimes, he really emphasizes, people on this board have, the importance of having, they do a 40-hour week with students on campus, and it's intensive, but he said, it's really good to see and to actually be with them and give them face-to-face feedback, and then have them do quite a bit of follow-up testing and continued observation virtually. So
I like that model compared to what we'd heard, when you're coming together regionally to a hotel and, sort of practicing on each other. It doesn't give you that real patient experience. It sounds like, Josh, what you learned was that in the hybrid model, where you practice intensely for 40 hours and then go back and actually administer tests to age appropriate humans who do unexpected things during tests, not like our colleagues or peers might. And so you're getting a little bit of the real world, how to respond during surprises that happen during the administration of psychological testing. So I like the idea of it including sort of some practice patients as opposed to just students.
And one thing that he said that I thought was really insightful, because they've they're one of the only school psych programs that are offer everywhere. They have students from all over the country. He said, we started the program to essentially allow for people to, be able to learn and get their degree and then practice in rural areas of Kansas. And he said, what we found was when you open things up too widely, what you get is a huge influx of out-of-state people. And it actually kind of defeats the purpose of why you were doing all this in the first place. And I thought that was really insightful. I was like, wow, because that's why At least that was my motivation behind a lot of this. But then it's like, well, if you become so accommodating sometimes, then naturally people are going to gravitate towards that, and it kind of defeats the purpose, the original purpose. So.
Any further discussion? Leslie, what's the current reg on that in terms of, is it the class that has to be completed on campus?
Yes, there's, all the psychotherapy and testing courses have to be completed on campus.
So would that require then a reg change to have a hybrid where they're doing some of the class virtually and some of it?
Well, if they're still spending, I mean, they're doing a 40-hour week, they're still spending enough time in the classroom to make it a in-residence class, I would think.
Okay, so it's not an all or nothing proposition.
Well, I mean, the regulation states that those just need to be done in residence. It doesn't say that there can't be any extra work done outside the classroom.
Welcome to the world of, trying to figure out what fits in a reg. And I think that's really, the gist of the work that's done here is trying to determine, does it meet kind of the overall desire of the reg so that people are getting good training and are adequately trained to do the service. And I think to Josh's point, we are now in a position of being able to think differently about how people are educated, but finding that appropriate balance so that we don't go so far that we're allowing people to take classes where, as Lauren indicated, they're really not getting the kinds of foundational educational experiences we want them to have in order to be able to appropriately and adequately use these instruments.
Yeah, I wonder if, I would say myself, if I was reading the regs and I saw that a class was required to be in residence, I probably wouldn't assume that because I'd spent 1 40-hour week on campus, that the totality of those credit hours were actually in residence. So the reg may have to have some more words in it to speak to that, if that's the path that we wanted to go down. I did get a request from physician relations to my department yesterday to see if we would be willing to do virtual ADHD testing for patients who are living in rural Kansas. And that made me think about this conversation. We don't do virtual testing. And I think maybe if it's not good enough for actual clinical care, is it good enough for training? And so, to be honest, that kind of popped in my head as I was thinking through, okay, well, if we're saying, well, maybe you can learn some of these things in a hybrid model, but we're saying in real life, we wouldn't administer them virtually. Is it a worthwhile skill to learn virtually if it's not usable in that way?
Yeah, so I think a really good point. I think most of the educational, programs have decided like there's some knowledge people can acquire in a virtual environment that's kind of foundational. And then if they bring them together to do face-to-face aspects of the training that they think can't be achieved virtually. So the hybrid model, as Josh describes it, seems to meet that, but it is kind of figuring out how many hours face-to-face is enough hours.
And something with the regulations, maybe not today, but I know this keeps going on, us talking about this, but I agree that the testing courses, they're, certainly a hybrid component or in-person component of some sort. But I think in the regs right now too, that also applies to, I think, like psychological theories or something like that. And that seems to me like something that could be done 100% online. Learning theories and things like that doesn't seem categorically different from other things that you would learn online anyway. So something to maybe consider there, because the more that we do require in residence or hybrid based, it does reach a point where it's going to be very difficult for programs to do anything a lot different.
Leslie, is the other required class the therapy class, or?
Yeah. 6 hours, 6 semester hours in psychotherapy, and 6 in testing.
Which is, again, back to Lauren's point, like, now it's widely accepted to be able to do psychotherapy via telehealth platforms. And so is that also an adequate way to learn how to do it? And there's, sure, because I know we do that, where we have supervisors sit in on virtual sessions like they would have sat in on a face-to-face session. Other folks have feedback on that?
Yeah, I would say that one feels more comfortable now that we have really moved and embraced a telehealth model, although we don't for sure know what will happen after the national emergency ends with regard to the use of telehealth and the limitations that will surround that from a CMS perspective. It may be a bit too soon to know what that will look like post-national emergency.
Other feedback on that?
I don't have feedback on the psychotherapy part because that does seem to be more acceptable televideo. On the testing part, one of the concerns that we have whenever we have new students come in or interns is that a lot of our testing requires them to be very structured in how they administer it. And that's been the biggest challenge for us is, making sure they follow the rules or the manual precisely so that you have consistent results across each provider. And that's why I think it would be hard to teach that course through televideos because it's all really performance based.
Yeah, I agree. I reflect back to my program and how to do what we did virtually, you would have to send a full battery of test materials to all of your students, right? Everyone would need a full waste kit and a WASI. And if you don't have that manual in your hand, and we all know you can't photocopy the manual to send it out to your students, but we slept with those test kits in our rooms. You had to memorize them. And so I also wonder, is the only time you'd be having access to the manuals during that 1 40-hour week? Or do they send a full kit to each student for the semester?
Yeah, the kits get sent to students and rotated, and it's a whole big, pretty large undertaking, lots of coordination, at least with this program. And but yes, one of the challenges programmatically, right, is you have to have enough kits and enough funding to do that. So and I can't speak to other schools about that, but it definitely is an undertaking, both to making sure you have enough kits and coordinating among students to make sure they send them different places and they have them and all that.
Anybody else? I guess the good news is it's not a significant issue in terms of there's not a lot of people being denied licensure because of this. So it doesn't feel like we're needing to move quickly, which is always a good thing, because then you can be more thoughtful about what it is you think you really need to do in the long term.
Have we
Josh?
looked at the regs for the LPs to see if there isn't any language in there that speaks to this issue?
The LP regs are the same. Their psychotherapy and testing courses have to be in residence.
I think that's kind of what I'm hearing from this group too, that it, to some extent, a large component of at least the testing part.
So at this point, Leslie, if a program like Fort Hays had a hybrid and their students completed that in the way that Josh has described, how would your staff know?
Well, for Fort Hays, they've sent their program to us, and they said those courses were in residence. If someone from another school applied, we would send a questionnaire, and that questionnaire asked if those courses were done in residence, and they would have to answer how it was completed.
So the university kind of defines that at this point?
When the questionnaire has our definition of in residence, and then yes, they would answer and show documentation.
So they have to kind of attest to the fact that they say the program meets the definition you've sent them.
Yes.
And so when they sent their hybrid, or did they send that to you guys?
Fort Hays?
Yeah, as Josh has described it?
No. They said that they were in residence.
Okay.
That's my memory anyway.
Is there a definition of in residence that requires so many hours? Or is it subjective?
Well, that's why I said 40 hours. The seat time, I mean, we go by seat time. That's what the regulation says, for an in-residence course for 3 hours. So I don't really know. That would be up to the board to determine if that would meet.
All right. Anything else on that issue? We'll take some ongoing time to kind of roll this around in our heads and think some more about it. But it doesn't sound like there's any significant desire to change the testing, at least. Still a lot of concern that that needs to occur in residence. And again, in residence, as is defined in the regs, means on campus, right?
Mm-hmm.
So that's the other thing, that these virtual universities having these regional meetings isn't going to meet that criteria. All right, moving on to a continued discussion on psychometricians. Josh, I think you had raised this issue and seemed like in the last meeting, a number of people had talked about how they were using some staff in that kind of capacity. Josh, did you have a desire to continue to discuss that topic?
Yeah, I so I did some more thinking about it after our call, and I did just some reasoning through it, kind of thinking. I won't go with all the details, but thinking about other services that different facilities that provide by quote unquote unlicensed people, and how it seemed to, I was able to kind of reason through that. Again, the reason why I raised it is because there just isn't any language about it in the statutes. And, I found David Fye, the New York organization that licenses psychometricians, and read through their stuff. Texas also has language in their statutes for LPs regarding psychometricians. I still think if the board was okay with it, I think there probably should be some sort of language in the statutes, just acknowledging that this is something that's, our license can utilize. And, there's some simple language that Texas uses and New York to kind of just acknowledge that, not to put parameters on it per se, but just to have some description and acknowledgement there, I suppose. So.
Josh, do you remember how they worded that in the other states?
And the thing I found, I can read it to you real fast here. So, like, you mean like the Texas statute deal? Is that what you mean?
Right.
Okay, it's a little long. Here we go. I'll try to skip over things that aren't relevant. So this is some Texas statute, and called employment of individuals not licensed by the council. Individuals licensed in another profession. A psychologist may employ or utilize individuals who are licensed members of another profession to provide only activities or services permitted by the applicable license or licenses held by that individual. In addition, a person licensed under Chapter 501 may supervise a licensed member of another profession to the extent permissible by that profession, so on and so forth. It kind of goes, B, unlicensed individuals. Psychologists may employ unlicensed individuals only to perform services which do not constitute the practice of psychology or the activities and services of another licensed profession. Permissible and duties include clerical stuff, scheduling stuff, processing stuff, but also data gathering, such as administering, proctoring, or scoring non-projective tests, obtaining histories, or obtaining documentation for record-keeping purposes, provided that it does not require psychological education or involve the provision of psychological services. And then there's another part that they can do there. Then there's a whole nother statute. It essentially goes on I think it's kind of repetitive of that, and essentially says, the person does not represent themselves as a licensed person. The delegating psychologist remains responsible for the psychological test or service performed by the person to whom the test or service is delegated. It kind of gets more specific with some of that stuff, I suppose. But I could send it to David Fye, and people could look it over if they wanted to, to see if we wanted to adopt some sort of similar language. I don't know what that process looks like, but I still think it would be nice to have something in there.
Lauren and Kari, were you the folks last time talking about using some people to kind of perform similar types of activities? Maybe you can kind of go over that with us again.
Yeah.
No, I didn't, but Lauren did.
Yeah, I did. We do use psychometrists for a lot of there are a lot of different things they can do that are quite helpful that don't eat into a licensed professional scope of practice. But for example, scoring a PAI or entering data that needs to go from the paper form that the patient completed into the computer for the automatic scoring to occur. There's other tests that you can administer and score without training, and so we do use psychometrists for that work. They provide, they complete that in collaboration with the psychologist that has requested the testing, and then it is the responsibility of the psychologist to interpret those results and write that report. And you have to state that there was a psychometrist involved and that was who administered or scored, or you define what they did, and that goes into your final report. That is current practice and works well. Especially as you think of a shortage of licensed clinicians, we don't want, like, anything we can spread out that allows a independently licensed clinician to fit another person onto their panel is a win. So I think it's overall good for us and good for the profession to get more patients taken care of and seen and diagnosed.
Yeah, I'm totally in support of it. That's why I brought it up, because I wanted to start, utilizing some psychometrists. But I just thought, well, I'll check out the statutes and see what they say as a responsible provider, and they just didn't have anything. So I just thought it would be good if they had something for us to acknowledge that. That's all. But I am in full support of usage of them for sure.
So Lauren, in your particular situation, is psychometrician a formal job title, and there's a job description in terms of educational requirements and what they can and cannot do?
Correct. To go into a little bit more detail, we have a combination of bachelor's and master's prepared psychometrists that work for us. Sometimes it's people who completed a master's program and didn't end up pursuing licensure, or completed their training in another state and weren't able to obtain licensure here in Kansas, but are still using their skill set and working with their patient population. Occasionally we'll have great psychometrists that were, midway through a doctoral program in psychology and for whatever life circumstance happened, ended up not completing the degree, but still this is their passion and their career and the types of work they want to be doing and the patients they want to be doing it with. So I don't think there's a one size fits all. I mean, I'm not personally aware of any programs that prepare psychometrists. It seems to be people who've gravitated towards it and then been trained by a doctoral level psychologist to do the scoring, or these are people who were trained in programs to do this, and then they're providing that under the supervision of a psychologist, maybe while they're continuing to work on their doctorate or their clinical license or whatever that might be.
Would you be comfortable sharing the job description as a kind of way for us to think about that?
I sure can.
And then Josh, I think you indicated you would send the information you had from Texas and New York to David Fye, and he could distribute to the group.
Yep, sounds good.
if as Josh was indicating, he was looking for something that said specifically that a licensed master's level psychologist or licensed clinical psychotherapist could utilize a psychometrician in the provision of the service of psychological testing. If that was in the regs, then I assume that means that that position would have to be defined somewhere.
I don't know, and I was David Fye. You would know better than I. But from what I've read in the other regs, I mean, it seems pretty loosely defined. There's not like kind of as Lauren was indicating, it doesn't seem like there's a list of qualifications that they have to have or anything like that. They pretty much just say a psychologist can use this person. Here's kind of what they can do. Here's some of the parameters, staying outside of licensed work essentially. But it's relatively vague from what I have found.
To me, that makes
I
sense.
would say,
Sorry.
no, go ahead. I bet we were going to say the same thing.
To me, that makes sense because each test defines who can do what. So it's like every test is different. And so certain tests you can use that, a psychometrician, and other tests you cannot. So it's largely dependent on what testing you're using too.
Yeah, that was exactly what I was going to say. So in our practice environment, we have a lot of psychometrists, and some of them are trained in tools, others are not. And so, we've paired psychologists, we've trained up and created core competencies for the psychometrists that are supporting different psychologists. If you're supporting a neuropsychologist versus a clinical psychologist versus a health psychologist, that is going to probably inform us as what type of core competencies that person would need to have depending on the area of psychological testing that they'd be performing. So I agree. I think it should roll up to the independently licensed clinician to be responsible for the psychometrist meeting those core competencies and making sure that everyone is practicing within scope. I wonder if there is language in not to sound like a broken record, but since doctoral level psychologists are doing this in Kansas, is there anything in the regs that the LPs are using that speak to psychometrists?
No.
Okay.
Yeah, I don't think it's a term that's defined, but we can look further and also kind of look at some of that language from Texas. But I think, just as a clarification, if there's a statutory change that's needed, that would be something that would need to go into a bill. If there's a regulation change, that is something that we can move forward on in a different time frame. But we might need to have a conversation with the attorney who helps out the board just to kind of get a little clarification if this would be something that might be better suited for a statute, or whether this falls under the statutes that already exist and we can deal with it in regulation.
The other thing, just as a reminder, that the function of BSRB is protection of the public. And so anytime you think about kind of bringing something to that group, any recommendations that come from advisory committee, that's really the lens that they're looking through. And so it's not kind of as an advocacy in terms of what would help a particular professional group, but more how do we make sure that the public is protected against somebody who might then say, okay, I'm going to have a bunch of people on my staff who aren't adequately trained because it's not well defined and it's very vague, and as much as we'd love to believe that all those practitioners out there would only do things that are in the best interest of the people they serve. We know that that's not necessarily the case, therefore that's why things are often well-defined. So just keep that in mind as well for further discussions on this topic. Anybody else want to weigh in?
Well, I did want to mention that the state hospital, Larned, uses interns and doctoral level interns and master's level interns to be a proctor for the testing. We don't currently have psychometricians, but I do know that in years past, and I'm thinking 10, 15 years ago, there was an official position at the state hospital for a psychometrician. So there's a possibility if you are inclined to try and find out. There was a job description at the state specifically for that. We don't have them anymore, but I do remember one lady who was hired and her job was a psychometrician. So.
Thanks. And if you can dig through the HR historical records at the state hospital and anybody can find that, we'd be happy to look at it. I think I mentioned back in the mid-'80s when I was in grad school, I spent a summer working at the state hospital in Winfield as a psychometrician. It was both my practicum and I was one of the few people that was getting paid.
Now that's not fair to tell us.
Yeah.
I will pull the job description from our organization as well. I also have a former colleague that is working as a psychometrist in the military, and so I think that there may be some thinking of where psychometrists would be most useful is where you're trying to gather data around large groups of people. And so if we're looking for other job descriptions, that might be places we could start to look for. I think there's also organizations that do some pre-employment personality testing, FBI, police departments, those types of things. Now a lot of that stuff has become privatized, but historically there were state entities or federal entities that did those, and I believe psychometrists were part of that assessment process too. But I'll bring to the next meeting as many psychometrist job descriptions as I can get my hands on, so we can look at the competencies that are sort of expected at baseline.
Great, thank you all. Guess we're ready for new business. Do you want to lead that discussion?
Sure. So I will pull up copy of, if I could go ahead and share the minutes from the meeting, that might kind of, sure. Okay. So there was a board meeting of the BSRB that happened in 2017. That might kind of be the good starting point for this conversation. So can you all see my screen here? Okay, great. So there was an inquiry. This is from a board meeting that took place in January of 2017. And what had occurred was that High Plains Mental Health Center had submitted a letter regarding concerns about after-hour care and how it should be handled. They had been receiving after-hours calls from clients that had been instructed by their mental health provider to contact High Plains Mental Health Center for crisis situations or services when their provider was unavailable, but they had not contacted the individual provider to make arrangements for this to be in place. And so the board had a discussion on that. And at the time, the board did agree that that was not a responsible thing to do. And so they mentioned that it would be helpful for the facility to speak to those that were referring them to see if an agreement could be in place, or that the facility could file a report of alleged violation against those individuals who had listed High Plains without contacting them as someone who could provide some of the services when they were unavailable after hours. And recently, the board has had a conversation about the rollout of the National Suicide Prevention Hotline, the 988. And there are certain practitioners that if they are not available after hours, they might leave a message. And in that message, the conversation was that if they have an after hours message and they're not available, is it sufficient for them to say, if you're in crisis, if you're in an emergency, dial 911 or dial 988, or to refer the person to another facility that you don't have a prearranged agreement with. And so the board had a conversation about would that be acceptable for someone to do that? And there was conversation that there should be some language in place more direct than maybe is currently in the unprofessional conduct regulations, talking about providers' responsibilities for their clients after hours in these types of situations, and what arrangements should they be making, or are they responsible for making for those clients that are in crisis when they're not available. But specifically now with the 988 hotline being rolled out, that was getting some of the focus of the conversation too, because there could be individuals who are not available who just mention, if you're in a time of crisis, call 988. So with that as sort of the starting point for this conversation, I'll go ahead and just share also a starting point from the unprofessional conduct regulations for the profession. So this is a copy of KAR, Kansas Administrative Regulation 102-4-12. And I have gone ahead and highlighted item number 41. In general, the BSRB, has authority to go ahead and list items that would be unprofessional conduct if an individual was engaging in these practices that is licensed by the board. And so under item 41, which I've highlighted, it says failing to seek continuation of care or abandoning or neglecting a client under or in need of professional care without making reasonable arrangements for that care. So that has been in the regulations for quite some time. The last time that these regulations had any updates was about 2008. So that is the current language that talks about continuation of care or making a reasonable arrangements for client care. The question is, given the conversation regarding the National Suicide Prevention Hotline, responsibilities to your clients when you're not available, that some facilities may simply be listed without having an arrangement in place. What is the role of the BSRB in this conversation? And is there additional language that could be added either to the unprofessional conduct regulations or to other places that might provide some more clear direction to practitioners in terms of the responsibility? And so as a starting point, I wanted to highlight that regulation. This is not to say that the language has to go in addition to that regulation. It could be a different regulation, or but I wanted to kind of provide that background as a starting point, and just kind of, it's been referred by the board to all of the advisory committees to have a similar discussion. And so I wanted to go ahead and kind of preface that. And Dave, did I mention any other parts of it, or do you want to add anything else on that point too?
Yeah, so for complete transparency, I was the one who sent that initial letter to BSRB. This was prior to my being on the board. And we got a response from the executive director at the time indicating that people who were doing that could be seen by the board as being in violation of the unprofessional conduct regs. So what we did in the past was, when we became aware of situations, we would send a copy of that email from the BSRB to the provider or agency and just say, hey, FYI, this is kind of a friendly conversation we want to have about the importance of your taking care of your folks. And that worked the vast majority of the time. Part of the issue, though, is, an expectation of providers that isn't specific and clear. So when we made our inquiry to the board, they reviewed the unprofessional conduct and they made a determination that in their belief it could fall under that, but it isn't specific. So a person reading that wouldn't necessarily understand, like, okay, it is my obligation to be available to my clients in crisis. And so part of, obviously, what we want to do is make sure providers understand specifically what their responsibilities are to their clients. So part of the reason we're looking at adding language is so that it would be clear to everyone. Because one of the things you do when you have to get licensed or re-up is to say you've reviewed your regs and you understand your regs and you follow the regs. So.
Yeah, and one more additional comment I'll put on that too is I mentioned earlier during my executive director's report, the complaint review committee, and it's made up of a subset of the board, 5 members. And so if there are complaints, the complaint review committee reviews the complaint and evaluates all the facts in each situation using the unprofessional conduct regulations. And then they would issue essentially a decision back to the person who had filed the complaint and the person who the complaint was alleged against. But that is kind of a process that what is publicly available generally are these unprofessional conduct regulations. And so
we appear to be frozen.
I have a few thoughts on that. Reading the reg, I would have interpreted the language. It currently is written, abandonment of care is in abandoning my patients, closing a practice, being gone from their care or departing from their care for a period longer than overnight. I think it was really inappropriate for them to put a community mental health center down without first having an MOU on file with that organization. But I think almost everywhere in healthcare now, when you call, even sometimes when you're calling a live business, you still hear a recording before someone picks up at a practice that says, if you're having an emergency, dial 911. And so I don't want to say that because it's mental health and that there's a 988 number that we wouldn't tell people to go to that I would never want anyone to not put a voicemail saying, go to the emergency room if you're in crisis. That's just if it's a medical emergency, you have to go get care emergently, which would be the emergency department, not not expecting a visit with your counselor at 1 a.m. So I think abandoning for how long, for what duration? Are we talking about overnight or are you retiring? Is important to delineate, and then making sure that we're not taking mental health to a place where we're adding more stigma and separating it more from medical diagnoses that we tell people to go to the emergency room in the middle of the night if you're having a crisis. We want our patients to know all of the places they can go to when they're having a crisis.
And I think that's part of, clarifying the language. So like I indicated, the board at the time clearly made an interpretation of the existing regs. And so what we would like to talk about is having more specific language. And I know, in our area, hospitals don't want people who are having non-medical crises clogging up their ERs, and police don't want folks who are having mental health crises in terms of however that's defined by the patient, to be calling 911 when it is something that they're not trained to handle. And so it really is making sure that people who are receiving mental health services have the opportunity to visit with somebody who's trained and could then say to them, you know, I can either help resolve this over the phone, or this is clearly a situation that's going to require you to go to the hospital. But somebody helping make that determination versus that being the response to anybody, because a crisis could be, I can't get my kid to go to school, and so they're standing in the yard screaming and I don't know what to do.
I think we'd want to define crisis in the voicemail, right? So if you just call your doctor's nurse's line and listen to it. If you're having a medical emergency, please go to the nearest ED. And so I see a big difference between what I'm hearing you say is a clinician to partner with them to help them make the decision. That's treatment. When you call 911 for a response, that's an intervention to keep you safe from imminent danger to yourself or others, not to fix the entire problem, but to get you safe. And that's step one. We've got to get you to a very safe place. Sometimes that's the emergency room, and no emergency room wants it filled with patients they don't feel like they have the toolbox to use, but the burden is on our emergency rooms to meet those needs and provide the clinicians in those EDs to support those patients, because we have a suicide epidemic and we have got to stop it. And I think that would drive people out of practice to know that they had to be on call 24/7 for crisis intervention, and that crisis intervention could include a 1 a.m. phone call that their kid wouldn't put their pajamas on. And I think we need to define emergency. And then those are also conversations to incorporate then with that patient who thinks a 1 a.m. pajama emergency, that may become a part of the treatment plan. So work on adding some coping skills.
You have that language. We'll pull up the language that we're kind of looking at, and then that way you can kind of read through it.
I worry and fear that we can't define some of the stuff because it's not going to be the same for everybody. You're saying this emergency, that's not an emergency, but I'm also thinking, well, to a parent who has mental health issues herself, and if she's got, the lights are turned off because she couldn't pay the bills, and, the 1 a.m. my child won't go to bed is like a final straw, that could be an emergency where she becomes, violent or self-harm. Like, I think it's going to be extremely difficult to define some of this stuff, because what's an emergency for us might not be for them. We talk about reasonable arrangements. What does that mean? To me, it seems reasonable, but to my client who doesn't understand, it might not seem reasonable. So I think this language is going to be very challenging to define and to have more specifics with. I work a lot with trauma, and what's traumatic for one might not have been traumatic to the sibling, if they're in the same situation and they see something or something happens, one might be affected a lot more than the other, or the other one was affected later on. So it's just going to be, I feel like this is going to be very challenging to give more specific language on. And that worries me a little bit, that I don't know what the right answer is. I just worry that, someone, how can you say that's not an emergency?
I think we don't say that. The patient tells us. So if they feel that that's an emergency and they need to seek emergent care for that, I don't think we tell our patients when they're in crisis. Our
But
patients
are you
tell
worried that if
us.
they call a number or go to a place, you know, I'm thinking the 1 a.m. example, there's no way this person could leave. She would need to call for help, right? Because, well, hopefully she wouldn't leave, he or she. I don't know. I worry about getting more specific on some of this language, just on how that's going to look and how it's going to affect everything, the whole system, but I don't know what the answer is, so.
All right, good points. Let's take a look at some language. The first example is in place, and it's from a large nonprofit health plan, and my understanding is that any of the practitioners who are part of their panel have agreed to follow this particular response in terms of crises. Can you all see that?
Yes.
So take a second and read through that.
So when the crisis is life-threatening, then it is appropriate to refer to the emergency room, or could be appropriate to refer to the emergency room.
Sure, and I think it's trying to kind of delineate out so that it just doesn't become the default for any particular crisis.
Right. Well, and I agree. That's what emergency rooms are for, life-threatening emergencies. And so that, to me, makes sense.
And
it also makes sense that you would not refer patients to go to the ED for a skills coping session. And so I very much understand needing to delineate this for our patients.
And two, I think your previous point as well, one would certainly hope, and I think this would make it clear as an expectation that people are talking with their clients about, here's what happens if you get into a situation after hours, and then talk about that and, you know, how those things could best be managed so you don't have people calling you every night for every little thing, but that may in fact become part of your treatment plan if somebody is really kind of that reactive to situations. But again, we don't want them also calling the police or ending up in emergency rooms.
I know located on the state line, or in Kansas City Metro, our situation is different than where things look in other places. But I can tell you, the reality is that a large portion of patients are coming to the ED, and even the community mental health centers are referring to the ED after hours.
And again, there may be circumstances where that's appropriate. What we're hoping to do is to just make it clear what their responsibilities are. So if somebody were to make a complaint, again, the BSRB's complaint review committee would have something that they could go to, and instead of, as was done previously, having to kind of interpret whether this was an abandonment issue or an example of unprofessional conduct, it would be clear to say, did you have this in place? And it would be easier for a practitioner to defend themselves if they said, yes, I had this in place.
Mm-hmm. I love this paragraph and the delineation it makes between not just simply referring everybody to the emergency room, but it being on you to determine that you're using the ED when it's an emergency, to be defined by the patient's definition of they know when they're in crisis, or if they tell us they're in crisis. I'm a believer that we should take that at face value and prioritize safety over everything else. I think this makes sense to delineate. I wonder the practicality of it in a solo private practice, or I don't know if we have folks on this committee that are in private practice that could kind of explain how they do it. I mean, we're blessed. We've got a psychiatrist on call 24/7. So I'm curious, like, what it feels like out in your practices.
Yeah. So, yep. So I work in a group practice with 8 other part-time therapists, and we have it in our contracts that essentially you're responsible to be on call for. Sorry, I have my toddler with me. You're responsible to be on call for your clients, and what ends up happening is that's the expectation. But we also have, because we're a group practice, we have people that cover for each other, when they're out of town or something like that. My only concern with this, I guess, with that paragraph is, during the nighttime, I think it's a little bit more explicit. I mean, I accept that if someone does call me at 1 a.m., then I pick up the phone and I have to determine and kind of assess what's going on. And, it may be talking them through something. It may be meeting with them, or, if it does seem like it's a true crisis, and, me meeting with them is really not going to, do anything, then it might be a referral to the emergency room. But my concern with that paragraph is during the daytime, because, as a private practitioner, especially for individual practitioners, if you have a full schedule during the day, and someone is in crisis during the day, you're hypothetically in a session, and you may not realistically be able to see the message from that client until the session is over. And then, I mean, I've had to adjust my day around crises before and cancel things, and that's happened sometimes. But, being immediately available during the day can be difficult.
Yeah, it would almost require either a daytime answering service that had the ability to interrupt the clinician, or a nurse or additional FTE in the practice to be that live person to answer and then coordinate, pulling the clinician out of the therapy session they were providing to do the crisis intervention. Which, again, is not all that practical when we have such a shortage of providers.
I mean, if I were in a session with someone and I got 3 calls in a row from the same number, I'm probably going to say, hey, something's going on. I have to step out. I really apologize, and, but aside from that, if a recognized number from one of my clients calls during a session, I obviously don't pick it up. May listen to the voicemail in between sessions, but yeah, I mean, I don't know if there's any data. There's a lot of solo providers out there, and or a lot of very small group practices, and having a nurse present is not feasible. Maybe having an answering service is. I haven't explored that myself, but yeah.
I would say based on current reimbursement, it would not be feasible unless the practice was really large. I mean, financially, you'd not be able to break even.
I do think that part of this is, I think what Dave was maybe suggesting is part of this is dealt with clients as part of your practice model, right? So like, you're communicating with them about what your practice does and doesn't do, and clients acknowledging that, and what is available, and kind of your availability, and there's acknowledgement of that.
So I believe the second paragraph, Dave, is your language. Is that right?
I think that's what you had sent me as well.
Okay.
The first paragraph was from Emblem Health, and then the second one was sort of a modification to incorporate it as it would apply to BSRB licensees.
Right. And again, remember our perspective here, the hat that we wear is advising to the full board, whose main responsibility is the protection of clients, people being served. Hard
I
to,
think of my thought disorder patients that might have an emergency in the middle of the night where they very much need to be taken by public safety and brought to the ED. And the life-threatening may be more of a danger to others than to self. But still, at 1 a.m., you have to keep them from harming others. So I wouldn't want to eliminate that someone could have an emergency that involves harm to others as the major risk factor, or the part that you need to intervene and keep the patient safe and stabilized. Maybe that's life-threatening if you interpret the word life to be not just your patient, but your patient's environment, the people that are in their life.
sure.
I'm trying to rack my brain to think about the patients that we do get brought to our ED that really could have been handled at a lower level of care.
Well, and I think that the other piece of this is there's likely that is occurring and that somebody is doing it. It just may not be the person who has the best knowledge of that patient. We, the agency I work for, anybody who calls our after-hours crisis line, we handle it. And then the next day, as we go through them, if they belong to a private provider, then we follow up with them. So it's not like we're not going to handle that. And only half the people who we see face-to-face, let alone just talk to on the phone, end up in the hospital. So the vast majority of calls we're getting do not require a person to be in the hospital.
Dave, can you, what it sounds like is you're wanting I guess, private practitioners to make a reasonable effort to provide the crisis service rather than immediately transferring to the mental health center. Is that accurate?
To the mental health center, to the ER, to the police, they're the ones who know the patient the best. They may, as Josh has indicated, have had conversations with the patient about this in the process of care. For some patients, and Travis, you probably did this as well when you worked at Iroquois, we have after-hour alerts in place for specific patients if they call, which is laid out in their treatment plan about how to respond to those folks. And we know if they ended up with people who weren't aware of their history, to the point raised earlier, didn't know about their trauma or didn't know about their specifically laid out preferences for how they wanted to be handled in a crisis. If that's not done, then we just run the risk of that situation becoming less helpful to the patient because it's being handled by somebody who doesn't understand their specific treatment history or the treatment plan that's in place for them.
I do also think, this was brought up earlier, but I do think there's a lot of interpretation that they can just use the 988 and that covers what any kind of crisis after hours. So I do think it's a good idea to define that. I do think there's still a lot of private providers that, that put us down as emergency contact also and have no agreements with us. Because they view the community mental health center as the person that's supposed to handle that. So I do think there is some confusion on level of responsibility there.
And there's nothing that nothing that would prevent a person in crisis from calling 988. And again, if they, regardless of whether they're in services, 988 is going to handle that call, and they resolve historically 90% of the issues over the phone. The downside of that is that's a completely anonymous, kind of experience, and so there isn't any feedback to the provider about, hey, your person called and they were in crisis, which would alert most providers to say, well, I should probably follow up with them. And so this is an evolving issue for sure. Josh, you had a comment?
Yeah, I was just going to say, there's been some discussion on what is an emergency. I think that's going to be very hard to define. But what Travis was saying, if there can be, my thought is there can be, if we feel like we need more in there about something along the lines of providers doing some sort of diligence with, intervention or guidance, where, through that language, the best decision may be reaching out to emergency services because that's what's needed. But there's some sort of, reasonable guidance there instead of a piece of paper that they get that says call 988 if you're having a crisis, or call the mental health center. I wouldn't call that reasonable guidance. That's just kind of not following up on crises, not attending to crises.
So I think my thoughts have drifted a little bit just based on where I'm working right now. I work part-time with the Wichita Public School District, and I'm thinking of, I've got kids that I work with and families that I work with in buildings all across the city. And yeah, I know them very well. But when a crisis is happening with one of my, 16-year-olds at their high school, I hear about it a few days later, and I hear about what happened, and it, some of the school staff's not trained in crisis, and sometimes it adds more to the trauma in ways. I mean, I feel like it could cause more damage sometimes, and they're working on providing crisis training, but not everybody's trained in trauma or crisis response. And then I'm wondering, am I responsible? Am I for them, and how do I communicate to them, to each school all over the district? I mean, there are two of us that do this position, and it's the largest district around. So it would be impossible for me to physically get everywhere as needed. But then it makes me question and wonder, am I responsible for some kind of care in that position? But I'm not their current therapist, but I'm helping the family to navigate mental health and how to be successful at school. So maybe not being their primary provider is the difference there. But some of them don't have outside community mental health support, which is why I get called in to help them. So it's kind of it's a little bit confusing to read these and to try and figure out how that works for a role like mine. So I don't know, but and maybe that's a unique situation. I don't know if are there a lot of complaints in regards to this kind of stuff? Do we get a lot of people saying they didn't give me what I needed, or they abandoned me in my time of crisis or care?
So as far as the complaint review committee, I don't believe we've seen an increase recently. Now the 988 did just roll out recently, so there may be some time for those to come in if they're related to that. But I think most of the continuation of care or coverage of care type complaints we receive is when an individual retires abruptly or just quits their position and doesn't make arrangements for the care of their clients in those types of situations. But that's the majority of the ones that we see currently.
And I think it's largely because the agencies that are handling that aren't making any kind of formal complaints. As I indicated, we followed up with several providers, provider groups to provide them the information that we got from BSRB, the email from Max Foster at the time. Again, in a collegial relationship of community partners, we want to be helpful. We don't want to just turn around and make a complaint. But again, I would go back to the issue that the BSRB has said that this kind of behavior, not having access to a clinician, would be viewed as unprofessional conduct. So it's not that hasn't already been taken before the board. The issue now is there a way for us to create language to make that clear so that providers understand it and have a mechanism by which to meet that, either themselves or through arrangements with other competent parties.
I liked what Rebecca said really kind of hit home. I was thinking about my children's school counselor, and at 3:00, her out of office email comes on and it directs everybody to the community mental health center. But the community mental health center wants those referrals. So again, there's a collaborative relationship in Johnson County where there's a large, very functional community mental health center that they're very lucky to have, that is not indicative of what exists outside of the metropolitan area. But if even in metropolitan areas with a really high number of providers, if school districts are already resorting to, it's go to the community mental health center after hours. This is a line that's not checked after school is over for the day. Does that say something about sort of the availability or the practicality of providing after hours support to all of your patients and all of your practices? Thinking of people who are supporting 5 or 6 schools, or I think you could default back to the school district and state that they have to have a plan. But I've read their plans and they all default back to the community mental health centers. And so I think there's some confusion about what role the community mental health centers want and should have over crisis intervention.
I think the schools are a little different though. I mean, it's a community partner. So like we partner with our schools too, we would want that. But it becomes different as the provider. And I think Rebecca mentioned that. And I do see it as a difference, but that's just my opinion.
Well, I think if it has been demonstrated that, the school and the CMHC have entered into that agreement, or it's highly likely that they share those clients, and as part of that, CMHC has accepted the obligation to be responsible for the emergency aspect of those services. Seems like there's a lot of different ways this could work. It's just making sure that it's done and not just either given to an agency that doesn't understand that it's in that role, or dumping it on ERs or the law enforcement because we don't have something formally in place.
But when I think back to the time at Iroquois, what comes to my mind is when we had a patient come in, we would have patient information clearly spelled out and have that patient sign, and that included what services we can provide and how to access those. I think it would be very challenging to try to define language for all providers and what after hour services are required to do, because we are in rural areas, we're in areas where we have a lot of resources and some that don't have many. So it would be very difficult to define it for all providers. But I do think that you can have language that clearly states you have to tell your patient what's available clearly so that they can make an informed decision. Is this right for me? If you're not going to be available when I need you, you need to tell me up front. But I think that's what comes to my mind.
Well, and I mean, in Wichita, I'm thinking of this practitioner that made himself available to a client who was in an emergency situation, agreed to meet the client at the office at like 7 p.m. at night, and was shot and killed by his client. So to me, it's like, at what point can I know if my client is potentially dangerous? Am I obligated to meet them, work with them if I don't feel safe, right? I would hope no. And I'm not sure the details or what made this therapist decide to go ahead and meet this client, why he felt it was safe or a good idea, but it cost him his life. So, I mean, safe, I know that we want to protect the public, but we don't also want to put ourselves in, in dangerous situations. If you have a client who is not stable.
Yeah, and I think that's why, the involvement of law enforcement or sending people to the ED is always a part of what's available, because there are situations that we wouldn't want clinicians, although the state is rolling out a mobile crisis response, and part of its goal is to really kind of avoid as much law enforcement contact as possible. So there's no doubt it's complicated. Think about this, and Josh, you had used some particular language that I forgot to write down. But anybody who's got some feedback in terms of the second paragraph that's kind of BSRB specific, if you can provide that to us, and we'll have additional conversations. As David indicated, each of the advisory committees is having this conversation. Clearly, from a BSRB perspective, the more similar the language is across professions, the better, just because it makes it easier as complaints come in, and in terms of also just educating providers about what the expectation is if they're not all completely different from one another. I appreciate the conversation and the thoughtfulness. All right, in the interest of time, as we're rapidly approaching noon, Anything else? Items people want to bring before the group?
No.
Thank you. Next meeting date? See, this is October, so that would be what, December?
And I know this meeting started at 10 a.m. I know sometimes in the past, the meetings have gone from noon to 2. So it may be a good idea to have a conversation just briefly about a good time for that December meeting. And if you do have dates that you're available, if we can have a conversation now if you want to.
So we would be around the 21st. The 21st, I believe, would work. Yep.
That works.
Yeah, I think anytime the 21st would be good for us.
How's the 21st for you all?
Is this of December?
Yes. Sorry.
It works for me.
Let me calendar real fast too.
Good for me, Josh.
Okay.
Yes.
Was that at the same time, 10 to noon?
Does that time work for everybody?
The 21st works for me. I do have a conflict at 11, but I can try to move it with as much heads up, if that time works for everyone else.
Does that
And
work
that-
for everybody else?
That may work for me. I may be out of town that week, but I'm not sure yet. So, but I will try to make that work that day.
All right. Thank you. We will then tentatively schedule for the 21st, 10 to noon. Great. All right. I would accept a motion to adjourn.
So moved.
Thank you.
Second.
Seconded. Thank you all. Appreciate your time and your thoughtfulness.
Thank
Have a
you.
great rest of your week.
Thank you.
Thanks,
Thank you.
everyone.
Thank you, everyone.
Yeah.